والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we'll continue the discussion of the lymphatic system. We have started the discussion of lymphoma, and this is the second talk concerning the imaging of lymphoma. You remember we have talked about the lymphoma of the central nervous system as well as the spinal cord. Then we discussed also lymphoma of different anatomic parts of the head and neck. And this part will discuss lymphoma of the thorax, including the mediastinal, pulmonary, pleural, and chest wall affection. Then we'll discuss the cardiac lymphoma and few words about breast lymphoma. Then we will talk about GI lymphoma, including esophageal, gastric, small and large bowel. Then we will show some cases of hepatic, splenic, and pancreatic lymphomas. Then in the last part of this talk, we will discuss the renal lymphoma, peritoneal disease, gynecologic lymphoma, the prostate and testicular affection, as well as involvement of the musculoskeletal system. Then lymphoma affecting the lung is usually Hodgkin disease, which is more common than non-Hodgkin disease, non-Hodgkin lymphoma. The incidence of lung parenchymal disease at the time of presentation is about 12%, and the involvement of the lung is in many times associated with the presence of mediastinal lymphadenopathy. And you remember that primary lymphoma anywhere in the body is usually rare. Then a lymphoma in the chest X-ray and also in the CT scan may simulate exactly pneumonic patches, and it may show air bronchogram inside. Then if you look to the chest X-ray and you see patchy opacity like this, then you think of a pneumonic consolidation, and you look for the clinical picture of the patient, and you start medication by antibiotic. Then you may be confronted by the non-resolution of the lesion or the persistence of the imaging findings. And you go to the CT scan and you see a lesion which is exactly similar to a pneumonic patch with internal air bronchogram, and this lesion is not responding to antibiotic. Then you go by biopsy, and then you know that this is pulmonary lymphoma. These are the manifestations of lymphoma in the lung. They include single or multiple nodules that are similar to metastatic disease. They may present by pulmonary lesions associated with mediastinal lymphadenopathy. The most common appearance in the lung is usually similar to pneumonic patches. Some of the nodules of lymphoma may show central cavitation, and sometimes you are confronted by reticular infiltrative pattern, which is similar to lymphangitis carcinomatosa. And in this CT scan, and you see these areas of ground glass veiling and patchy alveolar consolidation with some air bronchogram inside, exactly similar to pneumonic patches. And as written here, the most common finding of lymphoma of the lung is a mass-like consolidation, which is seen in about 68% of the cases. Then you may got nodules, you may got alveolar opacities, you may got pleural effusion, you may got mediastinal lymphadenopathy, and these are the forms of pulmonary lymphoma. And you see here patchy opacity with central cavitation in the apex of the left upper lobe may be mistaken for tuberculous infection, and there is another lesion in the middle lobe showing similar criteria in this pediatric age, and this patient is also known to have Hodgkin disease. Then you should go for the possibility of pulmonary lymphoma. And in this example, you see multiple nodular that are not exactly well defined. They show the fluffy appearance and scattered throughout the lung fields. This appearance may be mistaken for many other pathologies, and the diagnosis of lymphoma is usually reached by the biopsy. And this is also another case of multiple nodules in both lung fields, mainly in the left lung. The nodule shows some central cavitation, and then you can also see some air bronchogram inside, and this was also diagnosed as pulmonary lymphoma. This patient was diagnosed clinically as pneumonia based on the clinical picture of cough, breathlessness, and fever for 2 weeks. Then antibiotic therapy failed to show any improvement. Then the biopsy was confirmed the diagnosis of pulmonary lymphoma. And you have variable appearances of pulmonary lymphoma. Most likely they simulate pneumonic patches. And you remember that I have said if you have a pulmonary nodule or a mass with internal air bronchogram, the differential diagnosis is one of three. Either you are dealing with round pneumonia or pulmonary lymphoma or alveolar cell carcinoma. These are the three main possibilities. If the clinical picture can fit with pneumonia, then you consider pneumonia and you treat the patient by antibiotic and you do a follow-up, then you got clearance of the lesion. But the two other possibilities, which are lymphoma and the alveolar cell carcinoma, needs the CT guided or imaging guided biopsy to confirm the diagnosis. This patient is investigated for arrhythmias, and the chest X-ray showed multiple pulmonary nodules similar to or suggestive of metastatic deposits, and the CT scan showed biliary nodular opacities scattered throughout both lung fields together with some larger nodules and what looks like an area of pulmonary consolidation. And the diagnosis of lymphoma, non-Hodgkin lymphoma, was obtained after biopsy. Mediastinal lymphoma represents about 15% of all primary mediastinal masses and about 45% of anterior mediastinal masses in children, and 10% of mediastinal lymphomas are of the Hodgkin type, mostly of the Hodgkin type in about 60% of the cases. Then the symptoms are usually attributable to the mass effect of the lymphomatous masses, including retrosternal pain, superior vena cava, compression, dyspnea, and the cough due to compression of the trachea and the main stem bronchi. In this CT image, you see a bulky soft tissue mass in the anterior mediastinum displacing the aorta posteriorly, associated with bilateral pleural effusion, and this was mediastinal lymphoma. In the chest X-ray, you see bilateral pleural effusion, more on the left side. You see broadening of the mediastinal shadow, suggestive of the presence of a mediastinal mass, possibly due to lymphadenopathy, and the CT scan showed the mass as well as the pleural effusion. And this is another case of mediastinal lymphoma. The chest X-ray shows a huge mass related to the mediastinal border on the right side, and the CT scan showed the presence of a soft tissue mass in the retrosternal area with bilateral pleural effusion. And here is a case of Hodgkin lymphoma presenting by a big anterior mediastinal mass displacing the aorta and the superior vena cava posteriorly, with some mass effect on the trachea and the bronchi. The mass showed almost homogeneous contrast enhancement with minimal areas of breakdown inside, no matrix calcification. Pleural lymphoma, the primary type, is extremely rare, and the primary pleural lymphoma is less than 0.5% of all non-Hodgkin lymphomas. The pleural lymphoma may be of the Hodgkin type or the non-Hodgkin type, and these are the predisposing factors, including the Sjogren disease, rheumatoid arthritis, chronic lymphocytic thyroiditis, and the Epstein-Barr virus infection. And then this chest X-ray, you see complete opacification of the right hemithorax with obliteration of the costophrenic angle, possibly due to massive pleural effusion with underlying lung collapse, as the mediastinum is almost central with no contralateral shift. And the CT scan showed that there is massive pleural effusion with subtotal compression collapse of the lung, together with some pleural base masses, and this is one, and this is another one in the paravertebral gutter. And pleural masses are for the differential diagnosis of one of three: the mesothelioma, of course, which is more common, pleural metastasis, and pleural lymphoma. Then, in this case of a patient known to have non-Hodgkin lymphoma, you got diffuse, non-uniform thickening of the costal as well as the mediastinal pleura, together with pulmonary parenchymal infiltrations as well. Then, if you know from the history that the patient has lymphoma, then you should explain all the finding on the basis of the clinical data. And nodular pleural thickening is for the differential diagnosis between one of three: metastatic disease, mesothelioma, lymphoma. It is also stated in the literature that some cases of invasive thymoma may present as nodular pleural thickening, indistinguishable from mesothelioma. Primary malignancies that may produce metastatic disease to the pleura, of course, include the bronchogenic carcinoma, breast cancer, ovarian and prostatic cancer, gastrointestinal adenocarcinoma, as well as renal cell carcinoma. The role of PET scan is debated in evaluation of pleural malignancies, since all the types of malignancy will show increased metabolism or metabolic activity, and also the inflammatory lesions will show similar increase in the metabolic activity. Then the differential diagnosis may include lymphoma, mesothelioma, metastatic disease, and also some of the inflammatory conditions. The secondary pleural lymphoma or the metastatic pleural lymphoma is more common and is seen in around 20% of cases of lymphoma, and in up to 10% of these cases you have pleural effusion where you can detect malignant cells inside. Pleural involvement may be unilateral or bilateral, and it is usually more common on the left side. The most common type seen of pleural lymphoma is the large B cell type. And involvement of the chest wall can also occur either specific for the chest wall or extension of the pleural disease across the chest wall. This patient had a history of lymphoma and bony chest wall recurrence. Then you consider this lesion is lymphomatous and this lesion is also lymphomatous. And if you remember, when I talked about the chest wall pathology, I said that whenever you see a lesion that is centered to the chest wall, I mean it has an internal component and the external component of similar size, and you don't know any information about the clinical data, and you consider metastatic deposit, is the most likely you go for biopsy to confirm the diagnosis and to know the primary malignancy. But sometimes you can look for a lesion like this and you think of metastasis and it proved by biopsy to be lymphoma, but this patient is known to have non-Hodgkin lymphoma. Then you explain this very big mass as well as the pleural involvement as well as the lung involvement as well as the pericardial involvement on the basis of the clinical data of the presence of non-Hodgkin lymphoma. And this is lymphoma of the chest wall, appearing as a bulky, ill-defined mass infiltrating the chest wall muscles. And this is the follow-up after 4 cycles of chemotherapy, showing considerable or marked regression of the disease. Cardiac lymphoma is usually seen in patients with HIV infection, and this may affect the pericardium or the myocardium or both. In this example, you see a mass infiltrating the right ventricle and possibly the right atrium as well, with right-sided pleural effusion. Then this is the rest of the images of the previous case, and you see here a mass in the affecting the myocardium as well as the pericardium. This patient is known to have B-cell lymphoma treated for 15 years ago. Then you should consider this history for the diagnosis of lymphoma. But if you don't know anything about the history, there's initially thought for this patient to be a cardiac angiosarcoma, but the possibility of lymphoma was diagnosed by core biopsy. And breast lymphoma is the primary is less common than secondary, of course, and both breast lymphomas, primary type and secondary type, are rare, representing about less than 1% of all breast malignancies, and may be presented by palpable masses or diffuse breast thickening. The enlargement of the axillary lymph nodes are often present. It is known in the literature that lymphoma of the breast has no specific imaging findings, and lymphoma as well as breast carcinoma are difficult to be differentiated on the basis of imaging, and you need in almost all the cases to have biopsy to confirm the diagnosis. And if you see a lesion like this, which is seen in the mammogram as well as in the CT scan, there is a mass in the left breast, and the diagnosis is usually in the direction of breast cancer. But these are the suggestive features of breast lymphoma. Number 1, no speculation. Number 2, no architectural distortion of the breast. Number 3, no associated skin thickening. Number 4, which is one of the good stigmata, is the absence of microcalcifications, which are usually seen in cases of breast cancer. And here is a mass, bulky mass in the breast, subcutaneous retroalular, and The patient presented by painless, rapidly growing lump in the breast, discovered 2 months ago. And there is no microcalcification, and the lesion was diagnosed by biopsy to represent diffuse large B-cell lymphoma. And this is lymphoma by MRI. There is a mass in the breast, and this mass is strongly enhancing, and this fat suppression suppressed the image post contrast. The histopathology showed large B-cell non-Hodgkin lymphoma. Then we go to the gastrointestinal lymphomas, starting by esophageal lesions, and you know that most of lymphomas are in the form of diffuse submucosal lesions affecting predominantly default in the form of considerable mucosal thickening rather than the deformation of bulky masses or strictures. And here is a lymphoma of the esophagus extending into the stomach, presenting as diffuse thickening of the mucosal folds of the esophagus as well as the mucosal folds of the stomach. And one of the suggestive criteria of lymphoma by barium swallow is the presence of multiple masses. Esophageal cancer usually present by a stricture or a single mass, but if you see multiple masses like this, is one of the suggestive criteria. On CT scan, lymphoma and carcinoma cannot be differentiated on the basis of CT. And you see a bulky mass and the esophageal lumen containing air within this mass. The possibility of carcinoma should be considered first, but if you go by CT or by endoscopic biopsy, and sometimes you got the result as B-cell lymphoma. And gastric lymphoma represents about 25% of extranodal lymphoma, 50% of GIT lymphomas, 5% of gastric malignancies, and it is usually in about 60% of the low-grade malt lymphoma type. And you know that primary lymphoma is rare, but secondary lymphoma is more common. The relation of lymphoma, of GIT lymphoma, with Helicobacter pylori infection is high, and it is seen here in about 85 to 98% of the cases. And this is an unusual appearance of the lymphoma, presenting as a bulky mass in the region of the pylorus. This is usual presentation of carcinoma, but here you see that there is a soft tissue mass encircling the pyloric canal, which is markedly attenuated, and the mass is extending into adjacent to the undersurface of the liver, displacing the bowel loops, and this was proved to be a pyloric lymphoma. One of the usual appearances of lymphoma in the CT scan is diffuse gastric mural thickening, and this thickening may reach up to 2 or 4 centimeters, and this will be presented in barium as marked luminal attenuation, which is known as Leionitis plastica. And this is an appearance of lymphoma which is not a usual appearance. You see here considerable gastric wall thickening in the pyloric canal. Lymphoma usually presents by diffuse gastric mural thickening encroaching on the lumen. And these are the differences between lymphoma and the carcinoma of the stomach. Gastric carcinoma, it tends to be in the distal part of the stomach, here in the pyloric canal. Carcinoma is more likely to cause gastric outlet obstruction, while lymphoma do not usually cause obstruction. Carcinoma is more likely to extend outside the stomach and infiltrate the surroundings. Carcinoma is more focal, where lymphoma is more diffuse. The metastatic nodes of gastric cancer are usually small and necrotic, but lymphoma nodes are usually bulky, homogeneously enhanced, do not contain areas of necrosis. Small bowel lymphoma represents about 25% of all primary small bowel malignancies and 50% of all the primary gastrointestinal lymphoma. The predisposing factors are AIDS, celiac disease, immunosuppression due to organ transplant, and Helicobacter pylori infection. Lymphoma do not usually cause obstruction, do not usually cause perforation, but may lead to hemorrhage and may lead to malabsorption. And lymphoma of the small bowel, as regarded the barium meal fall through, usually presents by long segments of abnormality, and these segments may reach up to 20 centimeter in length. Then also diffuse bowel wall thickening similar to the stomach, and this is one of the peculiar finding of lymphoma in the small bowel, which is aneurysmal dilatation of the affected bowel loop. A small bowel obstruction is uncommon, and also perforation is rare. Regional lymphadenopathy is usually seen in about 50% of the cases. And this is what we mean by aneurysmal dilatation of the bowel. You got diffuse bowel mural thickening and dilated lumen, and the lumen contains some of the orally administered contrast media as well as air. And if you see this appearance in the CT scan, the diagnosis of lymphoma is highly suspected. Diffuse mural thickening entrapping part of the bowel containing some oral contrast material. And this is also a usual finding of lymphoma of the small bowel. You see the small bowel loop engulfed by this mass, which is the result of diffuse mural thickening of the involved segment. In here, you see this mucosal irregularity and the speculation, and also the separation between this loop and the other loops, and this is explained on the basis of mural thickening of this pathologic loop, which is confirmed by the CT scan, and you see the diffuse mural thickening, encroachment on the bowel lumen. And this is Burkitt lymphoma of the rectum. You see bulky mass affecting the rectal wall, encroaching on the lumen, which is opacified by gastrography. Also, lymphoma can affect the mesentery and the peritoneum. At that time, you will see bulky masses infiltrating the omentum, as you can see here, and soft tissue, ill-defined masses infiltrating the root of the mesentery, which are indistinguishable from the peritoneal metastasis resulting from ovarian or colonic cancer, for example. Then we see here the presence of bulky lymph nodes around the root of the mesentery, together with masses in the greater omentum, and also masses in the peritoneum in the pelvis. Then you may suspect the diagnosis of lymphoma, and many times you need the help of guided biopsy. Hepatic involvement by lymphoma represents about 16%, and occurs in 16% with non-Hodgkin lymphoma, 10% of Hodgkin disease, 50% of autopsy patients are affected with either Hodgkin or non-Hodgkin lymphoma, and the primary lymphoma of the liver is rare. Then the typical age of presentation is around 50 years with a slight male preponderance. Hepatic involvement is more common in non-Hodgkin lymphoma compared to Hodgkin lymphoma, and secondary hepatic lymphoma may affect the liver, either diffuse or in the form of multiple focal masses. but you may remember that the appearance of lymphoma in the liver is usually non-specific on the different imaging modalities. And if you see a mass in the liver and this liver is not cirrhotic, then you may think that this may not a hepatocellular carcinoma. But you know that the most common solid mass in the liver is the hepatocellular carcinoma, and some of the hepatocellular carcinomas may occur in the non-cirrhotic liver. Also, if you see multiple masses like this, the differential will include metastatic disease and the multifocal hepatocellular carcinoma. But if you see solid focal lesions in the spleen, and the most common solid lesion in the spleen is lymphoma, then you may interpret these lesions as lymphoma, considering those in the spleen. But if you see a mass like this in the liver, this is before contrast, and after contrast you see heterogeneous enhancement, the liver looks to be cirrhotic, then you should diagnose hepatocellular carcinoma. But in order to diagnose lymphoma, then you should have some of the of other supportive criteria, as something in the clinical data that the patient is known to have lymphoma, something in the imaging like focal lesions in the spleen, and you may refer for or you may find bulky lymph nodes which are characteristic of lymphoma also, or you may go for biopsy. And this patient had an old pleural disease with calcification, as you can see here. Then this lesion was proved to be a hepatic lymphoma. Lymphoma has non-specific CT and MR appearances. It presents by a single lesion or multifocal or diffuse. The presence of focal lesions in the spleen may help in the to support the diagnosis of hepatic lymphoma. But if you see multiple focal lesions like this scattered in the liver with no focal lesions in the spleen, then the differential diagnosis may include metastatic disease and multifocal hepatocellular carcinoma. You may need the help of needle biopsy to confirm the diagnosis. And this is an example of multiple hepatic focal lesions by CT and by MRI. The spleen is normal and there is no lymphadenopathy in the scanned area. Then the differential diagnosis will include metastatic disease and hepatocellular carcinoma, and you need the help of biopsy. In splenic lymphoma, Hodgkin disease represents about 27%, non-Hodgkin is about 35%, and there are 4 patterns of lymphoma in the spleen. Enlarged spleen with homogeneous CT density, solitary focal lesion, multiple splenic focal lesions, or diffuse infiltration of the spleen. Then splenomegaly is not a sign of lymphoma, but whenever the spleen is large or very big or huge, what we call massive splenomegaly, and this term is applied for the spleen which is reaching the iliac crest and crossing the midline. This is known as massive splenomegaly, which may be a presentation of lymphoma in some cases. But massive splenomegaly, which reaches the iliac crest and crosses the midline to the opposite side, can be seen in these conditions like malaria, myelofibrosis, leukemia, lymphoma, polycythemia vera, leishmaniasis, and thalassemia as well. But the usual appearance of lymphoma in the spleen is the presence of multiple solid focal lesions together with enlargement of the spleen. And this is what we mean by diffuse splenic lymphoma. You see the spleen is enlarged with very minute hypodense focal lesions totally infiltrating the splenic parenchyma, together with the presence of bulky lymph nodes in the celiac and porta hepatis area. And this is lymphoma of the spleen, multiple focal lesions, bulky retroperitoneal lymphadenopathy, some amount of ascites. And it's worth to know that 30% of patients with lymphoma have normal spleen, and 30% of patients with lymphoma have no splenic involvement. In pancreatic lymphoma, the primary type is rare, then the secondary type is more common, found in about 30% of patients with non-Hodgkin lymphoma, and the age of presentation is around the 55 years of age. And this is a case of lymphoma affecting multiple organs: the liver, they see a focal lesion; the spleen, another focal lesion; the pancreas, a mass which is bulky, uniformly enhancing, infiltrating the head and the body of the pancreas, as well as focal lesion in the kidney. And this is lymphoma of the liver, pancreas, the spleen, and the kidney. And this is lymphoma of the pancreas, presenting by obstructive jaundice, and this is the follow-up CT scan after treatment showing total regression of the tumor. Thank you very much. Walhamdulillahi Rabbil Alameen.